I think the main thing people should know is that most psychiatric disorders are caused by physiological problems, right? That's one piece. The second piece is we have massive increase in psychiatric disorders because of the physiology, because of the hormone interrupting chemicals, and also because of the breakdown in our society. Okay, but you cannot separate the loss of community that's rampant. It's so powerful to not be in a herd. Think of it, we're herd animals. You're out in the plains, in
Absolutely.
the savannah, wandering around on your own, you're going to be much more stressed and much more vulnerable. So we don't have communities. That's a big factor in the increase in mental health. So when you're looking at your kid and saying, wow, what's wrong with him or her, or your spouse, whatever, understand there are real reasons, that are things that they don't know about, that you don't know about, things that are not in their control. Yes, it's their responsibility. Yes, but it's really just the tip of the iceberg, the psychology.
How can we get to the root causes of anxiety, depression, and other psychiatric disorders? Today, we are excited to offer you a conversation with Dr. Robert Hedaya, America's leading functional psychiatrist, about how he approaches brain health and mental health in his clinic to produce long-lasting change for his patients. This conversation discusses root causes of psychiatric disorders, how lifestyle and diet can affect mental health, and how Dr. Hedaya uses HYLANE therapy, that's HYLANE therapy, in his practice to treat psychiatric disorders. My name is Dr. Andrew Wong, co-founder of Capital Integrative Health. This is a podcast dedicated to transforming the consciousness around what it means to be healthy and understanding the root causes of both disease and wellness. Don't miss this transformative conversation about the cutting-edge techniques that Dr. Hedaya uses to change the way we are approaching mental health. Welcome, Bob, and so glad to have you here.
Oh, it's great to be here, Andrew. Thank you very much. Look forward to our discussion.
Yeah, same here, same here. So as one of America's really leading functional psychiatrists, I think let's just get started with the basics a bit. How did you get into psychiatry, mental health, and then later, how did you get more into a functional approach?
Yeah, that's a great question. I kind of like telling this story. I was going to be a surgeon, actually. I was matched for surgery. And
Okay.
then I had I disliked psychiatry thoroughly. And then I had an elective in my senior year in medical school, and I had a great teacher who taught me hypnosis in about 10 minutes, and then had me hypnotize a young kid who had abdominal pain, which they couldn't find an etiology or cause for it. And so I went up and hypnotized him, and then I age regressed him backwards to age 3. He was 10 years old. I went back to age 3. I was like, uh-oh, he didn't tell me how to bring him back. So I kind of improvised a little bit. But the bottom line is he did great, and actually his pain went away, and I was blown away by the power of the mind. And I was like, wow, this psychiatry is the way to go for me. So I switched into psychiatry. Then when I went into psychiatry at Georgetown and National Institute of Mental Health, I did my training in both places. And then came out and just started doing cognitive behavioral therapy and psychopharmacology and some group therapy, just kind of what I was taught. And then I had a woman who had panic attacks for a year, and they did not respond to anything. And I finally woke up and looked under the hood, more carefully, and found that her MCV, the size of her red blood cells, was a little bit large. It was 101. Upper limit is 100. And so I did a little research because I really didn't know what it was. And so, it could be a B12 problem. So I did a Schilling's test, no longer available now, but I did a Schilling's test, gave her B12 injection. And in one injection, her panic was gone. And I was like, wow, what else am I missing? And
Yeah.
that's how it started.
It's so satisfying too to look under the hood, especially when people have been going to different clinicians over the years or just struggling with those problems by themselves, and then getting frustrated and then thinking that there's no answer, there's no hope. And then in a way, this kind of medicine gives people hope.
Yes, yes. And I'm sure you feel the same way, it's kind of like there's almost always an answer. you know.
So what are the most common kind of conditions that you see, nowadays in your practice? And if you can, well, let's go broad first, and then we'll kind of get into what we want to talk about in terms of the different technology that you've introduced and innovated here. So kind of maybe the top 3 to 5 conditions you see nowadays, although in functional medicine that might be a loaded question.
It's a
So
loaded
everything's
question
connected.
because if you were to look on my website, I was kind of looking at
I did look,
list of
yeah.
all these things we treat, and I'm like, this is crazy.
Exactly.
I mean, I'm treating all these things. I'm a psychiatrist, but the reality is functional medicine is such a broadly applicable method because it deals with kind of lots of chronic conditions. So I end up accidentally learning how to treat the osteoporosis. Well, I don't really treat anyone directly for osteoporosis, but they come to me with a major depression, and they happen to have osteoporosis. The osteoporosis tends to get better. So what do I treat? Major things that I treat are depression, mood disorders, let's say, would be a major category. Chronic fatigue syndrome, fibromyalgia would be a major category. I'm treating, early cognitive decline and early dementia and aphasia. We have actually reversed a couple of cases of aphasia. We'll talk about that later. We'll treat anxiety disorders. OCD is a little tough. We've had real success with OCD, but the patients have to really be willing to do what they need to do. And some patients with OCD won't do that, and some do. And the ones that do they get better pretty quickly. PTSD, we work with PTSD and ADD, well, that's standard psychiatric stuff and cognitive decline. That's kind of how I would say that. I have had success with psychotic disorders like schizophrenia. However, and there's a big however, the patients don't really stay on the program. They get better and then they drop everything. And so I really kind of stay away from that because it's a lot of effort, a lot of energy. You know how it is with the functional medicine, it takes a lot of work. And then to put in that time and energy and money, and then the patient goes off the program.
No, I treated someone with Walsh. I know you teach the Walsh, Institute method as well. And then they got better, started having a job, started having friends, and then they dropped off and they totally went back. So is that a social support issue or what is that?
No, I think I don't know if it's like an early emergence of the psychotic state. It could be an early emergence, like it's working for a while, then it stops working, and with the psychotic state, they kind of become a little paranoid, distrustful, and then they refuse to cooperate. I don't know if it's that, but we have non-compliance or failure to comply with a lot of people, so it's hard to really pin it down to that. It's a hard program. Changing your life, your lifestyle, your diet on a permanent basis is a big deal, and they don't have the bandwidth. They don't have much wiggle room or reserve. So if they kind of go off the program a little bit, it's probable that the psychosis emerges, and then you're just out of control.
Yeah, some of it's genetic or epigenetic, and like you said, there's not as much margin there. There's probably not as much margin for them on their lifestyle to stick with it. They have to really stick with it. Kind of wanted to talk about some other things. I've listened to you speak a lot recently about how mental health is almost over. I don't know if overdiagnosis is the right word, but kind of like this idea that once someone has a mental health condition, they have it for life, or they're kind of stuck with it. Just like when people like go to the endocrinologist or primary doctor and they're like, you have diabetes, and it's like a life sentence or something. Can you speak to that interaction between mental health, physical health, and how we can kind of move past the 1500s finally, basically?
I love it. Yeah, right. So I'll tell you, I have kind of become convinced that most psychiatric stuff is biologically based, and that what we're talking when we say, oh, it's a mental disorder, a psychological disorder, that it's not. Now, are there psychological issues? Yeah, look, you have a chronic problem. There's going to be a psychological overlay, right? But I think it's number one, really important to understand that most things have an underlying biological basis. Now, there are people who have character issues. All you have to do is read the paper and look at our leaders. Boom, you've got it. So there are characterological issues, right? And character can be changed, right? But personality is kind of inborn. In other words, are you harm avoidant? Are you novelty seeking? Are you reward dependent? How is your biology tuned? That's kind of, it's innate. It's modified by maternal, or the primary caregiver's influence in the early years and peers when you grow up. But I would say that much of what we're dealing with is biologically based, and it's just pretty clear. And now, as when we get into the quantitative EEG, some of the stuff that I see just blows me away. Just blows me away.
Yeah, yeah. I think we do want to get into that in just a second. Just a few other kind of intro questions here. So talking about the different, major things that you see from a quote unquote mental health perspective, what are some of those common biological root causes for those conditions that you see? Are there overarching umbrella kind of themes that our listeners can kind of gravitate towards in terms of like, hey, what's going on with anxiety or depression or PTSD?
Yeah, so unfortunately, I can't narrow it down to just a few more common things because, when I evaluate somebody, it's like Bredesen talked about 36 holes in your roof, 36 problems. It's more than 36 problems. It's hundreds of potential problems, and everyone's got their own unique
It's a pretty
combination.
expensive handy person, to fix all those. I don't know.
Yeah. Sometimes I joke around. I say, like, working with me is like going to the Mayo Clinic, except all the 12 doctors, they're all in my head. We do GI, we do immunology, we do infectious disease, you know what I mean? Endocrinology,
Yeah, it's all
genetics,
synchronized.
we do all of those things. So, I mean, the big buckets are the things that are on the functional medicine matrix, digestion, nutrition,
Hmm.
immune function and dysfunction, and hormones and toxins and epigenetics and structural issues, and then lifestyle issues and sleep and, rejuvenation. Those are the big buckets, but within
Yeah.
those buckets, there are many, many, many causes.
So today we want to talk about HYLANE, which I want to ask you how you came with the acronym because I'm a big fan of acronyms. But it sounds like it stands for hyperbaric oxygen laser therapy, and then neural therapy or neurofeedback,
And neural exercise,
neuro
neural exercise.
exercises. Um, does HYLANE mean anything else besides that? I know it's a fun acronym question really first before we talk
No,
about how
no,
it
it's
works.
just, I was just, take the first, it just popped into my head.
Yeah.
Uh, and, I was talking with somebody about it and it just popped into my head. I thought, oh, that's a nice way of putting it together. And
So let's talk about what it is, what HYLANE is, how does it work, and how does it work for different conditions that you see?
yeah, so HYLANE is hyperbaric oxygen, right? So hyperbaric oxygen, people may know, is being in a pressurized container, 1.3, 1.4 atmospheres pressure, which is equivalent to about 10 feet underwater, to as high as 2.5, or you could go up to 4 atmospheres. We don't do that. And the idea is that this actually, through multiple mechanisms, improves blood flow, right? You're putting things under pressure, so the small capillaries open up, you have more oxygenation, more nutrient delivery, you have changes in free radical production, stem cell production, lots of mechanisms of action, and it's helpful in healing the brain, even from head trauma that has been years before. Now, it doesn't revive dead cells, dead brain cells, but if there are cells that are kind of liminal, like I could say, they're kind of on the edge, they're alive, but they're not really doing too well, it can help those things. And we've seen, based on the QEEG that we do, that there's clear evidence that it actually can improve head injury post, years post the head injury. So that's useful. That's the hyperbaric oxygen. and you spend maybe an hour or an hour and a half, depending on the protocol, in the oxygen chamber, and maybe doing various things. And that's one piece of it. The next thing is the QEEG guided laser. So basically, we do a quantitative EEG, and I guess I'm not sure your listeners know what that is.
Yeah, let's definitely take a step back. What's the difference between quantitative and qualitative EEG? I think most people are familiar with EEG. If someone has a seizure, they go to see a neurologist, they get a diagnosis or of potentially like a seizure or something like that. What's the difference between that kind of EEG and a quantitative EEG?
So the quantitative EEG is fascinating, really. And basically, people, put on a cap, and the cap has 19 points at which it measures the electrical energy that your brain is producing, and it can do this accurately, really, through the scalp. And then there's an algorithm that has been worked out. It's called the reverse solution, which actually, amazingly, can actually, figure out what the electrical energy is, not only on the surface of your brain, but even deeper in your brain in all of these different areas, in lots of different areas. And then that is actually put into an image so you can actually see the surface of the brain and the networks in the brain. And I'll show you some of this later, and even the nuclei in the brain. And what I've found is that it correlates, and this is in the literature too, it correlates with diffusion tensor imaging. It correlates with neuroreader. I actually just last week was working on a patient's plan and was correlating her QEEG with her neuroreader volumetric MRI, which gives us the details in lots of specific areas in the brain. And there was actually a really nice correlation between.
Nice. Okay. Didn't know that. Yeah.
Yeah. So that's the quantitative EEG. So we take the quantitative EEG, and I've learned how to read it, and I'm still learning, frankly. It's a very complex tool. And then I, based on the symptoms and based on what I see in the QEEG, I decide where I'm going to apply the laser. The laser is coherent light, meaning all the photons in the light are actually in sync with each other, and peaks and troughs, like the waves in the ocean, they're actually in sync with each other. And the laser, you apply it to different areas in the brain depending on the symptoms and the QEEG. And then about 2.64% of the light penetrates through the skull, and then that's what you do. And the last part of this is neural exercise, and I didn't say neurofeedback. I said neural exercise because you're basically exercising the neurons in the brain in a targeted way. And sometimes it's with neurofeedback, sometimes it's with exercises like Brain HQ is a good platform. There are other things that people can do as well. So it's a combination of those things. So I have based those on a foundation of functional medicine, meaning the patient has done their functional medicine, and then typically I would go in and do this. More recently, however, I have two patients who had aphasia, meaning difficulty speaking. One woman was a 72-year-old African-American woman. She had diabetes, she was obese, she had dementia, she had aphasia. She could only speak a few words, really. And I was like, I don't know. I don't think she doesn't want to do the program. She doesn't want to change what she did. This is really, her husband begged me to please treat her. He begged me. So I said, well, let's just try the laser, just try the laser. We did the QEG, I did the laser. And she started talking. It was like I started crying and he started crying and she started talking. It was just incredible. Now, she wasn't normal. She was about 75% normal. I was able to eventually have a session with her for 45 minutes, just her and I. We had a psychotherapy session.
Nice.
So she had I don't know, maybe about 20 treatments. And then I have another case like that also with aphasia of someone who came to me from Illinois, and we just did this. So
Those are incredible results. Are those vascular related aphasias, like post stroke or something, or something
no,
else?
these are not post-stroke. These are more neurodegenerative. So,
Okay.
no, not post-stroke. Tried it on one guy who had a young guy who had a stroke. He was in his mid-30s. We did a few treatments. It wasn't clear. I thought he was doing a little better, but it wasn't really clear. So it made, and it doesn't mean it's going to work for everybody. We don't know yet. There are some people who have traumatic results. And I can actually, if you're ready, I'll show you a couple of slides.
Yeah, let's dive in.
So this is a QEG. There's a woman who, I'll actually show you, we published this article here just last March. Oops. She was about 58. She had mild cognitive impairment. She was having trouble with cognition. She had something called prosopagnosia, so she couldn't remember faces. So if she met you in the morning, she would not remember that she met you in the afternoon. So that she had for about 7 years. And she also had absent seizure, so which were never diagnosed. So we did a functional medicine program for about 6 months, and she was feeling better in many ways, but she was still having the prosopagnosia and still some trouble with finding words here and there and cognitive things, et cetera. So then I did a QEG, and I was shocked to see her brain was still actually pretty dysregulated. And this here, I'll just orient your viewers. Can you see my cursor, Andy?
Yes.
Okay, good. So here are her eyes, right? Her ears are here, and this is the back of her head. And anything that's gray is normal. Anything that's yellow is unstable, surface of the brain unstable, okay? So you can see here, there's a lot of instability on both sides of the brain and the frontal areas. This is a side view. Here are her eyes. Here's the back of her head. And here you can see other areas that are unstable. And here on the bottom panel on the left, you can see another view. And you can see that there's this instability. These are areas of the brain that are firing too easily, meaning the brain is lacking stability and lacking energy, right? Probably lacking energy. So the thing about, and the last one I'll explain to you here are these yellow lines and blue lines. The yellow lines are showing information flow from different Brodmann areas, different areas on the surface of the brain from one to the other, okay? So there's a lot of information. This is a small slice of what we look at. Here we're looking at 6 hertz, meaning this is a neuronal population that's actually working and firing 6 times per second. And here's the amazing thing. This red crosshair here is at her hippocampus. In each place, it's the area of maximal abnormality in her brain at this frequency, at 6 hertz. You can see on the bottom here, 2.74. She is 2.74 standard deviations from the normal. Now, this is after functional medicine. Okay, that's kind of shocking, if you ask me. I was pretty shocked. So then we did the HYLANE, and basically we did the hyperbaric oxygen. We did the laser. We did the laser. And the first treatment, I was not expecting this, but the first treatment, her facial blindness went away. I wasn't even, the facial blindness, frankly, wasn't even on my map. I never saw a patient with facial blindness. I didn't know what facial blindness was. She introduced me to it. It was, remember, I'm a psychiatrist, right? So facial blindness is not my thing, right? She came in the next day and said her facial blindness was gone. I came home that night and I told my wife that my mind was blown. I don't get this. I couldn't understand it. I could not get it. So after 30 treatments, here's her brain. And you can see it's completely normal. And her hippocampus now is 1.25 at the maximal, 1.25, but on average it's 0.45 standard deviations from the, she's normal. She's normal. There's a little bit of stuff going on here. You see these yellow areas, but she's basically normal. Okay, so this is astounding. Now, she had a mild cognitive impairment. She had also, I didn't tell you, ApoE4, the genes for, Alzheimer's disease. She had 2 copies, so she's homozygous. And, there were some relatives who had it. And so she had a process going on in her brain, because of the ApoE4, that was pushing her towards dementia. And we pushed it back, okay? She did 30 treatments, and then we said, all right, let's stop. Then we repeated the QEG a month later, and it actually improved even further. So the brain was still using the energy and whatever it was, and her brain continued to improve. Then we checked her QEG 3 months after we stopped, and she regressed. And she regressed because the underlying processes, underlying pathophysiology was taking over again now that we were not working on her brain. So she needs continuous treatment to maintain her brain health. And that's what we learned from her. Show you, this is the article we published. I said, oh, this is a slide, so you just, let me just come through here. Okay, so this is another one. Okay, now this is a vascular dementia, okay? This is the surface, this is the surface of his brain, okay? This is after functional medicine. This panel on the left is after functional medicine, but before the hyperbaric and the laser. And what you see here is areas, these dark blue lines are worse than the light blue lines, but these are areas that are not connecting with each other in a meaningful way. They're not able to share information. We can blow this thing up here, the red semicircles here, tell us about each Brodmann area and how it's connecting from one side to the other. So this is where he was before his hyperbaric and laser, and then this is after his hyperbaric oxygen and laser treatment. And you can see it's a dramatic improvement in his connectivity. This connectivity is pretty disturbed. And then here we looked at a specific network in his brain. So this guy was complaining, everything bothered him, everything was like something important to him, and that's the salience network. Salience, what's important to you? What's salient, right? So the salience network for him was actually abnormal, and you can see that here. This is specifically the salience network, not connecting, different parts not connecting to the others, right? And you can see some poor connection here on both the right and the left side. Up here, you see the salience network. I don't know if you could see this. And you see these white areas here that are kind of outlined?
Yes.
So that's the salience network, okay? And you can see here the salience network as well, right? So this is what happened after the hyperbaric oxygen and the laser. You can see basically his salience network is normalized. Is essentially normal here. And he reported to me that things weren't bothering him so much anymore. That means things weren't so salient, right? So this guy had a vascular dementia, a lot of cardiovascular disease, and he was having multiple problems, and he was an executive. So one day I called him. I texted him, actually. I texted him, and I was just checking in on him. I said, John, how are you doing? He says, I'm doing great. He texts me back. He says, my memory is my new superpower. So I thought, well, John's having a good day. That's all. But then I thought, well, let me do some testing, objective testing, and see how he's doing. So we did a CNS vital signs, and we had one in May of 2019, and then that was May of 2020, a year later, okay? And so you could see here, just to go over this, the verbal memory when he started was a 66th percentile. Now, this guy was a very bright guy. and he was in the 66%. After the treatment, he's in the 95th percentile. So he wasn't really kidding, you know.
No, it's great results.
So
Amazing.
this is mild cognitive impairment. We have other cases where I'm going to show you one more case. If you, I don't know if you want to, you probably don't
Yeah,
want.
yeah,
Okay.
we can. Yeah, sure.
So this is a 40-year-old guy, whoops, with a 28-year history of unremitting depression. And this is his baseline QEG up here, right? And after functional medicine. Now, the thing to look at here, I think, is you see my arrow here. Anything over 2 is abnormal, okay? So this is where he came in. So he had abnormalities here in delta. These are the neuron populations that are operating 1 to 4 times per second. And then he had issues here in low beta, which are the neurons that are, say, 11 to 14 or so cycles per second. And then you could see he had also in high beta abnormalities. There are a lot of abnormalities in him, but he's a bright guy. This is his peak frequency here. And you can see here is pretty high at around 11 or so. He's a bright guy.
Yeah.
And then after functional medicine, you could see these frequencies are better, right?
Yeah.
He's under 2 standard deviations, except in high beta, he's still abnormal, okay? And so then basically we gave him 15 lasers, and he still had something going on here. And then we added neurofeedback, and we still have something going on here. He's getting better. And this is his QEG, his neuro navigator QEG. And you can see pre-treatment baseline here, and then after functional medicine. You can see after functional medicine, the brain is still not normal. It's still not normal. This little horseshoe here is a marker of depression. And you can see the parietal area is still a problem, et cetera. So there's still a lot of problems. And this is after 15 lasers here, and then after lasers and neurofeedback, he's better. And the thing, I don't think I have it here. No, I don't have it here. But we have mood charts that he kept consistently. And basically, he has been depression-free now for about a year for the first time.
That's incredible. That's incredible. I mean, just seeing, and for the listeners who haven't been watching the video, go onto YouTube. But if you're listening, what Dr. Hedaya is saying is basically that depression, mild cognitive impairment, vascular issues can all be, the brain can basically essentially be healed and restored, like with that matrix of functional medicine as well, but as an underlying, kind of homework in the beginning. But it sounds like for some people, this is where you even start, is with HYLANE.
Yeah, I'm now, like I said, I used to think, well, we got to get the functional medicine in first, I think it's always better, right? Because it's like a plant, right? You give it good nutrients, good soil, right? Water.
Sure.
The plant is going to grow. The brain is going to do better with get rid of the toxins, put in the trophic factors, etc. Right. It's got to do better, but people still can respond even up front, right? So I don't know the limits of that yet, but they can.
How many years have you started doing HYLANE? When did you start developing it?
So I started in about probably, I'd say 2017.
Okay. I just have a couple of just detailed questions. I know some of the listeners might be asking this, but on the oxygen, HBOT or hyperbaric oxygen therapy, are you recommending a soft chamber, hard chamber? Like what? It sounds like there's different options really for people, but does it matter really how much atmospheric pressure you do on that?
I think it depends on the conditions, but we have a soft chamber, and some people do hard chambers, and the learning that I did with Paul Harsh and others seemed to indicate that for most cases in my realm, and the kind of people I'm treating, that the soft chamber is adequate. But there may be situations where you need higher pressure. But the pressure seems to be the main active ingredient. However, there's a guy named Efrati. I don't know if you've heard of him. So he's doing
Yeah,
protocol.
vaguely. Yeah.
Yeah, in Israel, he's doing
Okay.
protocols in Israel. He's been studying hyperbaric oxygen now for more than 20 years. He uses a protocol that we've just recently started using where we put people in the chamber for 90 minutes and we have them do 100, as close to 100% oxygen as we can for 20 minutes, then 5 minutes off, and then 20 minutes on, 5 minutes off. We repeat that cycle a couple of times, 3 times total. And during that, we have them do neural training. The idea is that you can actually increase stem cells. The brain kind of thinks it has a relative hypoxia, even though it's first it's hyperoxic, right?
Mm-hmm.
Then you take away the oxygen, and really there's plenty of oxygen, and the brain says, oh, relative hypoxia. It takes several weeks, and then the brain says, this is bad, let's make new neurons. And
Oh, cool.
it makes some stem cells, etc. So that's what we've been doing now.
That's really
You know,
cool. It's kind of like a homeostasis, or something where the body's trying to get back to that.
yeah, the body's putting in its adaptive mechanisms,
Yeah.
right, so
Yeah.
that it can really step up to the plate, and you get benefit from it. You know.
Well, I mean, this is such an important discovery or innovation. I feel like this is the next level of functional medicine and neurology, psychiatry. It's all combined. I mean, certainly in our practice, as you know, we see a lot of people with mental health conditions, but it's all linked to the physical and getting into neurology now. And I agree that sometimes when you treat the gut hormones, immune system, structural, sometimes it's hard to touch the brain. So I love the fact that you created this like laser therapy and then combined with oxygen and neuro exercise, because sometimes the brain is the most important area to treat. Often it is, I would say.
Yeah, I think so. I'm going to show you one other thing. I'm going to share my screen again. It's really now. It's not this patient, but I'm going to use this as an example, as a visual. Okay, so if you see this panel here on the right here, right? So there's a pathway here that starts in the frontal area. It's the inferior frontal occipital tract. It goes back from the front to the occiput, right? And it controls vision, and which makes sense, right? And it also controls reading speed. And then there's a vertical occipital pathway, which is in the back here. And I had 2 patients where I treated those pathways. One was a guy who he was paranoid, and he had visual distortions where he thought everyone was looking at him with a disdain his whole life. So imagine you're going through life and everybody's looking at you with a scowl. It's not hard to get a
Not
little.
a great way to live. Yeah. Yeah.
Not a great way, and it's not
Mm.
hard to get socially phobic, right, et
Yeah.
cetera. So we did his QEG, and boom, his whole brain was normal except for this inferior frontal occipital tract and the vertical occipital tract, both involved with visual facial processing. Whoops. So we treated it. My thing doesn't want it. So anyway, we treated it with 4 treatments, and his visual distortions melted away. They
That's
melted
amazing.
away.
Wow.
It's incredible. And then we just treated another woman, and his reading speed improved, which I didn't even know that the reading speed was involved in those pathways. And he told me, he says, my reading speed has improved. So I did a little research, and I was like, lo and behold, reading speed is involved. So that was a kind of check, because you always wonder how much is placebo. You obviously want to be sure that what you're doing is helpful and working, etc. So it's quite mind-boggling, this technology.
And I love these QEEGs, and then just to think about how, cholesterol, blood sugar, things like that, we can check in blood work. This is almost like a lab test
Hmm.
for the brain, brain health, and then
Yeah,
be able to do something about it too, being able to focus, that area. You know how in functional medicine we always talk about test, don't guess. I mean, this is kind of like what this is
but that's exactly
for
what
psychiatry. Yeah.
that's exactly what it is, and it's superior to SPECT scans because SPECT this is so much more detailed, and we can do this in a person's home. I mean, we could ship. We do it all over the country. We can ship the equipment to people in their home,
That's
and
great.
it takes an
That's so
hour,
great.
maybe an hour and 20 minutes, and they ship the equipment back to us.
So the oxygen needs to be done in person. What about laser? How does that work? Do people come to the office for that, or?
So the laser, people come to the office for the treatment, and then there are some people, like the first case I showed you, where people will actually buy their own laser, and
Okay.
then I direct them on how to use it and check in
Okay.
periodically, make sure they're doing it properly. You
Yeah.
know, the thing with the laser, just so people understand, is obviously, there's a good amount of research now on this, but it's still considered experimental, right? So according to the World Health Organization, you're allowed to use something like this in someone where there's actually, you have a neurodegenerative disorder, there's no treatment, right? You have aphasia, there's no treatment, so there is no treatment. And so you're allowed to try something experimental, and we did. And then you have to publish, which we did. And then you want to do a trial, which we're trying to set up, so that that's kind of the way to go. So this is not something you're going to treat, an 11-year-old with ADD.
Yeah.
You're not going to do that, right? Not with
Because
the
there's standard therapies, there's already established
yes, you
therapies
would
that
not
you
want to
do.
do. And
Yeah.
before we do this, we always need an MRI, make sure there are no conditions inside the brain, et cetera, that would be dangerous, et cetera. So this is limited to people in certain conditions like cognitive decline or treatment-resistant depression or things like that.
They've
Uh,
already done CBT, they've already tried ideally trauma-informed therapy and things.
all of those things, right? Exactly.
And then I was going to ask you, how do you decide when to weave those HYLANE treatments together with things like EMDR and therapy?
Yeah. So, I mean, the patients, I would say that if someone has a history of trauma, emotional, physical trauma, sexual trauma, et cetera, if they haven't dealt with it and it's affecting their ability to care for themselves in a proper way, they always have to deal with that first before engaging in our treatment,
Yeah.
because the treatments are complex. And if you don't have a partner on the other side, you as a physician, healthcare practitioner, is the limit to what you can do. So we always get them involved in that kind of thing. EMDR is, actually, I forget her name, the woman who developed it. I can't remember her name. Anyway, I interviewed her probably 15 years ago on my radio show, and I was talking about EMDR with my wife and daughter actually last night. I don't know how effective it is. I just haven't seen much, but there may be practitioners out there who are great with it. I don't intend to like knock it or anything, because it may be great for some people and it may be great practitioners, but I just haven't seen that much benefit from EMDR myself, So
Okay.
we always,
Yeah, I think it does depend on each person too. I think we should touch on medication since you have a background in obviously psychiatry, psychopharmacology. Where are you these days with using medications? Are you using them much in your practice anymore, or how's that going?
yeah, I'm using much less than I used to. In the mid, up until the mid to late 90s, I was using a lot of medication. That's what I did. I did the whole medication psychopharmacology polypharmacy thing. Then when I got into the functional medicine and I wrote my second book, we ended up getting, it was a bestseller, so we had so much, I couldn't even treat all the people that were coming, so we just selected people who would do what I asked them to do, And after a few years, that's when I had my big aha. After about 3 years or so, I was like, what's going on here? I'm barely prescribing meds. And everyone's getting better, and their osteoporosis is better, and their type 2 diabetes is gone, and even a woman whose MS lesion disappeared. I'm like, what's going on here?
It's
I thought,
awesome.
I must be lying to myself. So I hired a statistician to go over all my data. And we had, I think, 23 treatment resistant depression patients. And the data did show actually that all 23 were normalized by 10 months. In
That's
fact,
awesome.
without any changes in meds. I didn't take them off their meds. I just didn't make any changes, except I added lithium for one patient who was suicidal, and lithium helps reduce the risk of suicide. So I think meds are a good tool, but they're widely overused, and I wouldn't want to be without them, but I think they're widely overused.
Yeah. And then just a take home for the listeners. Thank you so much, Bob, for being on here today. What is one thing you wish everyone knew, whether it's themselves or their loved ones, about treating psychiatric disorders?
I think the main thing people should know is that most psychiatric disorders are caused by physiological problems, right? That's one piece. The second piece is we have massive increase in psychiatric disorders because of the physiology, because of the hormone interrupting chemicals, and also because of the breakdown in our society. Okay, but you cannot separate the loss of community that's rampant. It's so powerful to not be in a herd. Think of it, we're herd animals. You're out in the plains, in
Absolutely.
the savannah, wandering around on your own, you're going to be much more stressed and much more vulnerable. So we don't have communities. That's a big factor in the increase in mental health. So when you're looking at your kid and saying, wow, what's wrong with him or her, or your spouse, whatever, understand there are real reasons, that are things that they don't know about, that you don't know about, things that are not in their control. Yes, it's their responsibility. Yes, but it's really just the tip of the iceberg, the psychology. It's just the tip of the iceberg.
This, we're dealing with a lot in functional medicine, this almost like individual health, but then there's like this social,
Yeah,
emotional community matrix
yeah, exactly.
too.
That's
Yeah.
exactly right. Exactly right.
Well, speaking of that, for the larger community, thank you so much, Dr. Hedaya. Thank you so much, Bob, for being here today. We do have one fun closing question for all of our guests here. It is a pretty interesting one, I think. What is one thing under $20 that you think has changed your health for the better that you'd like to share?
I would say this is very personal, okay? But for me, it's the belief that there's a creator, and that the creator has a plan, and that everything is part of a plan, and everything has meaning and purpose. If you can grasp that, and it takes, admittedly, it's a challenge, but I've been working on it now for at least 15 years, maybe longer. If you can grasp that, then your stress, the stress that you experience in life, is reduced by 80%. Then you may have pain, but you won't have suffering.
That's a great point, and great points, and definitely doesn't really cost anything. I guess it costs, more of a attention and intentionality and working on it,
Yes.
like you said. But that's amazing. Have that meaning and purpose, believing in a higher power. Great answer. It's probably the best answer I've heard so far. Great. Well, thank you so much, Bob, again. Dr. Hedaya, how can listeners learn more about you and work with you?
So we have a website. It's called Whole Psychiatry. It's like WHOLE, like Whole Foods.
Like Whole
Only,
Foods. Okay.
right. It's like
Yeah. Yeah.
wholepsychiatry.com. And there's a lot of information on the website, tons of information on the website. And if they want to contact us, we do a couple of things. I can be your physician if that's what you want, or we can actually do an educational consult so that I can do a workup, it's whatever, and then help you to work with your physician and try and be flexible with that. But the work we do is very, very, very thorough. I spend about 4 hours to 5 hours with every new patient, and myself, and then hours making their plan, et cetera, et cetera. It's very, very detailed. So it's really not necessarily for everybody. It's for people who really are ready to dig deep, need to dig deep, and motivated and able to do something like that.
I love that. It's so great. It sounds like amazing grand rounds with the patient for 4 to 5 hours.
Yeah.
And you're right here in the DMV. You're local. So for those of you listening there in the Washington D.C. area, Dr. Hedaya's practice is in Chevy Chase, correct?
In Rockville, actually.
Oh, Rockville. Okay, I should
We were
come
in
by and
Chevy
listen.
Chase. We were
Ah,
in Chevy.
that's why. That's why I thought you were there. So yeah, Rockville is great. I'll have to come by sometime. And yeah, thanks so much again, Bob, and great to see you here, and hope to connect with you again soon.
It's a pleasure. Thank you so much for having me on. I appreciate the opportunity.
Thank you for taking the time to listen to us today. If you enjoyed this conversation, please take a moment to leave us a review. It helps our podcast to reach more listeners. Don't forget to subscribe so you don't miss our next episodes and conversations. And thank you so much again for being with us.